Discussion on some important aspects of tetralogy of Fallot. Four cardinal features of tetralogy of Fallot are malalignment ventricular septal defect, overriding aorta, infundibular pulmonary stenosis, and right ventricular hypertrophy. Please subscribe to this channel for future updates. Click on the subscribe button. Press the bell icon after that for all updates. The variability in clinical presentation of TOF correlates with degree of right ventricular outflow tract obstruction and the size and anatomy of pulmonary artery and its branches. They usually present with cyanosis in childhood. Squatting on exertion and cyanotic spells are classical symptoms of TOF. The lifted up apex, core and sabot, peasant's boot-shaped heart due to the right ventricular hypertrophy is seen well in this chest X-ray PA view. The right-sided aortic arch is seen indenting the tracheal air column on the right side. There is mild cardiomegaly and right atrial enlargement as well in this adult person with tetralogy of Fallot and associated inferior wall myocardial infarction. The lung fields are oligemic due to the right ventricular outflow tract obstruction in tetralogy of Fallot. Tetralogy of Fallot is the commonest cause of right aortic arch in an adult. Color Doppler echo in TOF. The blue color is the flow of blood from right ventricle across the ventricular septal defect into the overriding aorta. This causes desaturation of aortic blood and cyanosis in tetralogy of Fallot. The blood from the right ventricle preferentially enters the aorta, which is overriding the ventricular septal defect, because right ventricular outflow tract is narrowed in tetralogy of Fallot as a result of infundibular pulmonary stenosis. Parasternal long axis view in tetralogy of Fallot, diastolic frame showing the aortic valve in closed position and mitral valve in open position. The aortic valve appears to impinge on the ventricular septum, but the ventricular septal defect with aortic override and connection between right ventricle and aorta is evident just above the septum. Apical 5-chamber view in tetralogy of Fallot demonstrating the subaortic ventricular septal defect with aortic override. 50% of the aorta is committed to the left ventricle, while the remaining half is committed to the right ventricle. The VST in tetralogy of Fallot is a malalignment VST, which results from the malalignment of the ventricular septum with respect to the aorticopulmonary septum during embryonic development. The shift of the aorticopulmonary septum towards the pulmonary side produces both the ventricular septal defect and the narrowing of the right ventricular outflow tract. Van Praag and colleagues hypothesized that all the features of tetralogy of Fallot are due to the underdevelopment of the infundibular septum and its sequelae. They termed this as a monology, called by others as Van Praag's monology of Fallot. Apical 5-chamber view in tetralogy of Fallot with color flow mapping in systole, with right to left shunt across the ventricular septal defect. Blue stream moving from the right ventricle across the VST to the aorta is clearly visualized in this frame. There is also a blue stream from the left ventricle to the aorta. Color flow imaging shows high velocity jet in the pulmonary artery arising distally from the descending aorta, suggesting a patent ductus arteriosus. This is one of the compensatory mechanisms to improve pulmonary flow in tetralogy of Fallot. Another mechanism is major aortopulmonary collateral arteries or MAPCA. Intrapulmonary collaterals can also occur in tetralogy of Fallot. The image is in the parasternal short axis view. Continuous wave Doppler interrogation of the jet guided by color flow mapping picks up the continuous flow with a peak gradient of 61.5 mm of mercury. The gradient is calculated from the velocity measured by the device using the formula P equal to 4V squared. Findings to be sought in an aortogram in tetralogy of Fallot are aortic regurgitation, coronary anomalies, MAPCAs, PDA, and side of the aortic arch. Still frame from an angiogram with radiocontrast dye injected using a pigtail catheter kept in the right brachiocephalic artery, showing major aortopulmonary collateral artery arising from the right internal mammary artery. MAPCAs are seen in severe forms of tetralogy of Fallot and pulmonary atresia. MAPCAs usually arise from the descending aorta. Strictly speaking, the collateral arising from right internal mammary artery is not a major aortopulmonary collateral, though it can be considered a MAPCA in the wider sense of the meaning. When the lungs are supplied by multiple MAPCAs, they are unifocalized prior to definitive surgical repair of tetralogy of Fallot. Connecting the distal end of MAPCAs to a single vessel is known as unifocalization. Collaterals to the pulmonary arterial branches can also arise from the bronchial arteries within the lungs. Hilar collaterals can also occur in pulmonary atresia. Surgical approaches to TOF would include palliative systemic pulmonary shunts like Blalock Taussig shunt, Waterston shunt, and Potts shunt. Complete repair is accomplished by patch VST closure, resection of the subpulmonic obstruction, a transannular patch around the pulmonary valve annulus if necessary, and a takedown of prior shunt. Placement of a transannular patch for widening of the RVOT usually leads to severe pulmonary regurgitation. Systemic pulmonary shunts lead to high flow through the pulmonary artery, elevated pulmonary vascular resistance, and branch pulmonary artery distortion. Survival after repair is worse in patients with prior central shunts, that is Waterston or Potts, possibly due to the higher unrestricted pulmonary blood flow. Some patients with Blalock Taussig shunts may survive unrepaired into adulthood. These patients should be evaluated for pulmonary artery stenosis and pulmonary hypertension. Those who had pulmonary valve atresia or anomalous left anterior descending coronary artery may have had prosthetic or homograph conduits with or without a valve placed between the right ventricle and the pulmonary artery. Endothelial overgrowth can occur within the conduit and cause obstruction of the right ventricular outflow tract. This can be treated with balloon dilatation or surgical replacement of the conduit. Pulmonary regurgitation is almost universal after corrective repair of tetralogy of Fallot, more so in those who require a transannular patch for widening of the right ventricular outflow tract. Hence, an early diastolic murmur along the left sternal edge following repair of tetralogy of Fallot is most often due to pulmonary regurgitation, but a few cases may also develop aortic regurgitation due to various reasons. Aorta is dilated in tetralogy of Fallot prior to repair because it receives a major portion of the output from the right ventricle as well as the left ventricular output. This is the reason for a high volume pulse in tetralogy of Fallot. Thus, dilatation of the aortic root is one of the potential reasons for aortic regurgitation in tetralogy of Fallot. Other causes are lack of support due to a subaortic ventricular septal defect and valvular deformation resulting from retraction of the surgical patch. The risk of sudden cardiac death in operated tetralogy of Fallot is 25 to 100-fold than in the general population, and it can occur decades after correction. The risk is related to QRS duration more than 180 milliseconds. QRS widening is related to pulmonary regurgitation, right ventricular dilatation, and conduction defect. Atrial arrhythmias are also common after TOF repair. Hemodynamic effects of pulmonary regurgitation include chronic right ventricular volume overload, right ventricular dysfunction, and exercise intolerance. Pulmonary valve replacement can decrease QRS duration and stabilize right ventricular function, though the timing is unclear, but earlier would be better than later. Right ventricular function can be evaluated by echo or magnetic resonance imaging. It is well known that adults with previously operated tetralogy of Fallot can develop ventricular tachyarrhythmias and die suddenly. They are prone for ventricular tachycardia as well as atrial tachyarrhythmias like atrial flutter and fibrillation. Syncope may be a forerunner of sudden death in some individuals with operated tetralogy of Fallot and calls for evaluation. An annual incidence of 0.4% sudden death during the first 25 years after surgery has been reported. Both the surgical scar as well as the dilatation of the right ventricle and right atrium due to the pulmonary and tricuspid regurgitation are thought to have roles in arrhythmogenesis. Highest risk is in those with marked cardiomegaly with cardiothoracic ratio more than 60%, severe pulmonary and or tricuspid regurgitation, QRS duration on the electrocardiogram of more than 180 milliseconds, and a QT interval dispersion of more than 60 milliseconds. Surgical correction of the pulmonary regurgitation with a valvular prosthesis and tricuspid regurgitation by annuloplasty may decrease the chance of atrial and ventricular arrhythmias. This is more likely if surgical repair is also accompanied by mapping and ablation of the re-entry circuit of the arrhythmia. Here are the first set of journal references. Second set of references are here. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.